Evening session with Dr. Pyatt as we are co-moderators for the RLI Power Hour webinar series. Before we get started, there's just a few logistical items that we wanted to run through with you. So when you join this evening, you join through the Zoom platform. On the Zoom window is the Zoom control panel, which you can see an image of here. I'm circling it with my cursor. We want to draw your attention to an icon on the Zoom control panel, the Q&A icon. The Q&A icon is what you would use to ask questions of our speakers. So if you click on the Q&A icon, up comes the Q&A window, you type your question and then hit send, and then we will see it on our end. You're welcome to submit questions at any point during the webinar. However, they will only be collected and not asked on your behalf until we get to the dedicated Q&A session at the very end of the webinar. One other item that we do want to make you aware about is that this is a recorded webinar, and that includes the Q&A portion. So all participant questions will become part of that recording. So I'm now going to turn things over to Dr. Pyatt to introduce this evening's faculty. Dr. Pyatt.
Thank you, Jen. We have quite an all-star lineup of faculty this evening. I'm going to give a brief overview of each member of the faculty. We have 6. Josh Cooper is currently the Vice President of Government Relations and Economics Health Policies, and that we learned today is his 25th anniversary with the ACR. Howard Fleishon, MD, FACR, MMM, is the immediate past chair of the Board of Chancellors, and he's currently proudly serving as president of the ACR. Tom Hoffman, CAE, JD, is vice president of the legal department with American College of Radiology in Reston, Virginia. Greg Nicola, MD, FACR, is chair of the ACR's Commission on Economics. Elizabeth Rula, PhD, is executive director of the Neiman Health Policy Institute. And Dr. Bill Thorwarth, MD, FACR, is the chief executive officer of the ACR. And I'd like to turn the program over to our first speaker, Josh Cooper, who will talk about the evolution of the NSA. Josh?
Hello, Dr. Pyatt. Thank you very much for the introduction, and thank you for acknowledging my limited amount of service with the ACR. I'm very happy to be with the organization for 25 years. Again, my name is Josh Cooper. I'm Vice President of Government Relations and Economics Health Policy. Again, thanks to Dr. Pyatt and Dr. Nathan for hosting us this evening. Hopefully, we will be providing you with a nice overview of the latest on what is going on with regard to the implementation of the No Surprises Act. I have been asked to hopefully move forward on my screen. There it is, a little delay. The evolution of the No Surprises Act. And I think most everybody understands that protections for consumers against surprise billing arose from, I'm sure, news stories that we all have seen of patients who received exorbitantly high or surprise medical bills. And I think the vast majority of these folks were insured. But obviously they went to out-of-network facilities or out-of-network physicians who charged them out-of-network prices that they weren't expecting. The states glommed onto this. The states started off the legislative efforts and enacted some protections for consumers. The varying approaches were picked up and put together and debated at the federal level. There certainly was broad consensus among stakeholders to protect the patients who were in the middle of both the insurers and the providers. However, it was a challenge to determine the amount the insurers would pay. Sorry, there we go. And more importantly, and I think what we'll probably get out of this, how that process should work. So after 2 years of congressional debate and several legislative iterations, the No Surprises Act was signed into law on December 20th, 2020. Waiting here for the next slide. I apologize, I'm having trouble advancing my slides.
Josh, if you, yeah, there you go. If you click your cursor over the slide itself, it'll allow your up and down buttons to advance for you.
Thank you. So the legislation itself was an arduous process. It took, as I mentioned before, 2 years to put together. There were several iterations from the jurisdictional committees that the stakeholders poured over and debated. I think that at the end of the process, I think the stakeholders held firm and were able to go ahead and get some of the things listed in the slide here into the bill or removed as necessary. So we were able to remove an original monetary threshold. We were also able to remove provisions using the median and network. And very importantly, we were able to insert language that explicitly excluded Medicare, Medicaid, and workers' compensation for determining what the rates would be, so they couldn't be considered in calculating them. And with these revisions, the physician community hoped that the new law would ensure that consumers would be held harmless and that an equitable process between physicians and insurers would be initiated to handle disputes. That's what we hoped. Implementation, unfortunately, has been a little different. The implementation by the agencies has raised many concerns among the provider community, starting off with the interim final rule, the part 1 on July 1st. As you can see here, we had concerns with regard to the way that the qualified payment amount, or QPA, was calculated. We also were a little concerned that bonuses and risk sharing were not included in the calculations as well. The concerns continued with the interim final rule part 2 on September 30th. And this is where all the kind of the fun and the trouble began with regard to the QPA being the primary determinant, at least according to the agencies. And this QPA determinant started the ball rolling on several lawsuits that we will certainly discuss in more detail. And Dr. Nicola is going to go into more detail on the implementation process and some of the other concerns that we've had moving forward. I'm sure, as many of you all are aware, we have participated, or there have been several lawsuits with regard to the rollout of the No Surprises Act, specifically with regard to the independent dispute resolution process, as well as calculations. The Texas Medical Association kind of kicked everything off. The AMA and the AHA, as well as ACEP, ACR, and ASA, filed similar lawsuits in different jurisdictions. As you will hear later, as a result of winning the first TMA lawsuit, there was a second rule. The second rule didn't really, in our minds, fix the original problem. So the TMA issued a second lawsuit that has been resolved as well. And there have been 2 other lawsuits recently from the Texas Medical Association, referred to as TMA 3 and TMA 4. Should be noted that the Texas Radiological Society was also named as plaintiff in TMA 4. And Tom Hoffman will be discussing in more detail ACR's role in these suits later on in the program. So with regard to advocacy, as this moves forward, some ongoing ACR activities, we have been reaching out to members. We have been trying to keep them up to date and informing them of the latest on how the implementation is emerging, the latest on the lawsuits, and hopefully what to expect down the road. We've solicited membership to determine which states or practices are experiencing difficulties at this time. We will continue to do that. We've been monitoring instances of unscheduled payer efforts to cancel or renegotiate contracts, which we feel is probably something that unfortunately may increase later on. And I think where radiology is most vulnerable down the road. And the ACR is working with some practices already who have contacted us with regard to gathering data from them. So we have some data to share with lawmakers in case we need to try and rectify some of these concerns legislatively. So again, with regard to ongoing activities, one of the benefits of what we have been doing with regard to payment over the last several years, with that coalition of over 118, we've worked closely with many of the larger organizations, and those type of relationships have allowed us to get together and concentrate on other issues, surprise medical billing being one of them. So with our colleagues and other stakeholders, we're in the process of scheduling preliminary meetings with physician supporters, participating in agency meetings that have occurred already and are ongoing. And just kind of as a side note, as the 118th Congress convened and continues to go, we all must understand that if we do decide to go forward with any type of legislative solution, it may be difficult given that we are in a terribly divided Congress. And so the legislative process, although warranted, may be difficult. And later on in the program, Dr. Thorwarth will be expanding on our coalition efforts, and Dr. Fleishon will be going into more detail about some of our advocacy sensitivities. So that's what I have for you with regard to the evolution. I think the other members of the panel will be filling in, I'm sure, the many blanks that I've left for you. So I appreciate your attention, and I look forward to your questions as we move ahead at the end of the program. Thank you.
Josh, thank you for that very important background information. And our next speaker will be Greg Nicola. He will talk about challenges with how it was enacted in the final rule and other pertinent items. Greg?
Thank you. One second here, just trying to. There we go. Great. So as Bob has introduced me, I'm going to be talking about the challenges of how this law was enacted. Josh did an amazing job of summarizing all the provisions and the historical evolution of this law. And I'll talk to you a little bit about what our members are telling us. And I certainly want to thank the ACR staff for collecting members' experiences with this law. That's helped educate me. I also want to thank one of the Economics Commission members who has dived deep into this law, Rich Heller, who's helped guide me through what all these different provisions have meant for our membership and radiologists practicing. My disclosures are up to date on the ACR file, and they're on this slide. So I want to start off by kind of summarizing the different types of challenges that you may face from the rollout of this legislation. And we like to think about them before you actually enter the independent dispute resolution, is where the actual decision is made for whether you are granted the amount of money you think you're owed or the insurance company is. During the independent dispute resolution, what challenges might you face? And then the challenges you might face even after, when it's all done and the decision's made. And then finally, we seem to be focusing on challenges faced by an out-of-network provider entering an IDR, but there's actually challenges faced by practices are actually in network, and I'll go through a couple of what we've seen in the market. So before you enter the independent dispute resolution, there are three main things you have to watch out for. Eligibility of whether it's eligible for the IDR on the federal level, the cost of the process, and wait times. And the way I like to think about eligibility is that there are certain plans that might not actually qualify for the federal dispute resolution, in that there are states that also have out-of-network legislation, and how the federal law was written is that the deferral to the state law happens first. So if it's a plan that's governed by the state law, you won't even enter the federal dispute resolution, and you need to know that. In fact, there's enough confusion. There's been complaints that we really should have the insurance companies label that up front, so that we don't spend a lot of time spinning our wheels. For cost, let me briefly describe why costs are important. Josh touched on a very important point. The ACR and our coalition argued there should not be a threshold amount to enter the IDR, meaning if you think you're owed $5 or $10 more, that's not too little. You can go after that in this process. However, there clearly is a cost to go through the process, and whether that $5 to $10 is worth it depends on how expensive it is to go through the process. The costs include the entry cost into the IDR and the cost of the arbitration. Now, the cost of the arbitration can be deferred to the loser. So if you think you're going to win, some of that costs come off your plate. But in order to enter the IDR, you do have to pay a fee, and that is your fee. Now, the federal government was aware of this, and they try to disperse the fact that there is going to be a cost by allowing us to batch claims. And batching means, well, you have a group of claims that you all want to argue against, and if you batch them together and then only have one IDR initiation cost, well, that should make the process cheaper. Well, of course, the devil's in the details. There's some issues here. One is that batching is quite restrictive in that not only do you have to batch claims of the exact same CPT code, they have to be the exact plan type. So you could be dealing with one insurance carrier but have slightly different plan types, and you can't necessarily batch those claims. You only have a 30-day window of items that have to be batched together. Otherwise, you have to start a new batch. So batching has become quite restrictive. And in fact, I think it was the ACR had a press release showing a practice that might have 18,000 claims, may end up having 9,000 batches, and that a typical batch would only include 2 claims. So batching hasn't been that effective. And the cost of the IDR initially was only $50. So you had to have a delta between what you wanted, what you thought you were owed, and what you were going to get paid of $50 in order to make the process worthwhile. But recently, the Health and Human Service Department increased this fee by 600% to over $300, making that delta harder to achieve and really making you scratch your head on whether you want to bring low-level claims into this process. And this actually started another TMA lawsuit that Tom will go into. The fact that the IDR entry fee has gotten so expensive. Finally, I talked about wait times, and I want to share the report from these 3 agencies, Health and Human Service, Department of Labor, and Department of Treasury. They put out a report that showed between the second and third quarter of 2022, there were 90,000 claims overwhelming the IDR process. And at that point, only 5% actually were filtered through the IDR process. So the wait times have actually starting to become very onerous and difficult. And we expect these wait times, at least for the short interval, to increase. Tom will talk to you about the Texas Medical Association second lawsuit, where they actually won recently, and the Health and Human Service Department made an announcement on February 6th that the IDR process is now stalled until the agencies had a chance to write further rules. So basically, you're really going to have explosion of wait times now, and that backlog is going to take some time to work through. So now let's switch to what are the potential challenges during the IDR process. Well, there's 2. The second one's hopefully going to become less relevant. The first is how is QPA calculated, the qualified payment amount? How is that calculated? Because that could affect, the ultimate decision of the arbitrator. And then the first, even after the first Texas Medical Association law, the Department of Health and Human Services still wrote regulations saying that the QPA is the right amount. That started the second Texas lawsuit where we think that the HSS will now have to move away from that. But as of now, QPA being the real impertinent factor in making the decision by the arbitrator is a real problem in this dispute. So why are the calculations a problem? Well, one is that carriers really kind of set the QPA themselves, and they can use what we call ghost rates. Now imagine this, primary care doctors in your community who might never do CT or MRI, believe it or not, in their fee schedule, they might have CT and MRI fees negotiated. And because they don't care about those fees, because they don't provide that service, they may be extremely, extremely low. And the commercial carriers are actually allowed to potentially use those to drag down the whole fee schedule for somebody who actually needs an MRI IDR process. That brings me to the second point. Physicians of different specialty can be used against each other in their fee schedules. So I gave an example already of primary care potentially having an MRI on their fee schedule, even though they might not provide that service. Well, that can be used in calculating the QPA. Unfortunately, Josh also touched upon this. There are certain practices and departments and health systems that have negotiated very low radiology payments. In return, they have potential to share an upside risk and incentives. Well, those low negotiated payments can be used in calculation of the QPA, excluding what the payments would have been with a positive adjustment from risk sharing. And that's pretty detrimental to the value of the QPA. And then self-insured plan data, where someone is, fully, a company is fully responsible for its own monetary assets inside an insurance plan. They may have negotiated some very low rates for some services, and those could also be used in the QPA. So there's a lot of problems with the QPA calculation. The last one I didn't talk about is who gets to audit the QPA process. Is there auditing going on? How frequent is it going on? Is it, so that's a real problem if we can validate a commercial carrier's QPA and believe it's honest. And then the last thing I talked about during the IDR that's a problem is QPA primacy, meaning that the arbitrator has been directed under the second set of regulations written around this to still look at the QPA. We expect this to change now that the Texas Medical Association's second lawsuit has been decided, saying that QPA primacy can't be part of the rule because the legislators didn't intend that. We expect further rewrite of the regulations, and hopefully that will be diminished. Finally, after the ADR, there's a chance that payments don't come on time, or even come in fragmented amounts. And how do we audit this? How do we dispute this? What is that process? These are unknowns but concerns. Finally, I talked to you a little bit about most of the stuff I talked about is if you entered the IDR because maybe you're an out-of-network provider. Well, what about in-network providers? I can tell you I have some personal experience with this. We were negotiating a fee schedule for an imaging center, and usually you just get bottom of the basement fee schedule rates at first and you have to negotiate. Well, we actually had a carrier who refused to even deal with us. They said, we're just not going to put you in our network at all. And we're a well-established, reputable group. Took us some time. We did get them back to the table and ended up negotiating rates. But there's this new kind of self-assurance from the carriers where I've never heard in my career that they just wouldn't even negotiate with you. I'll even give you below Medicare, but they wouldn't negotiate at all. And so that's a real problem for those of us in network. And then something that's really kind of really hit my stomach hard is we've seen a number of letters go out by carriers here, Blue Cross North Carolina, Blue Cross Tennessee. We've seen letters going out to in-network groups saying that you need to renegotiate or we're going to cancel your contract and you're going to have to go out of network. And this is a calculated move by the insurance companies. They've looked at their QPA calculation and said, wow, this group's getting way higher than our QPA. We should force them to argue with us in arbitration. and really kind of make them renegotiate their contracts. And this has been an unfortunate occurrence of this law. Our heart goes out to our members. It's one of the things that drives us every day is to really get this part of the law fixed, and that this nonsense shouldn't be happening. These are groups that have done the right thing and negotiated contracts with carriers, and now the carriers are turning against them. So that's all I had for this section, and I look forward to the questions during the question and answer section. Thank you very much.
Thank you, Greg, for talking about all those challenges. Quite a few issues there. Our next speaker will be Dr. Bill Thorwarth. He's going to talk about leadership opportunities and examples such as multi-society collaboration and lawsuits and things at the individual practice level. Bill?
Thanks very much, Bob, and I really appreciate the opportunity to be here. My thanks to our coordinators, our co-chairs for the opportunity to talk with you about this really, really important process this evening. And also thanks to all of our listeners and attendees for recognizing this as a significant challenge and spending your evening with us. Let me see if I can get there we go. I have no financial disclosures or no disclosures relative to the presentation, but I didn't list these outside activities because my segment of the presentation has to do with collaboration. And I think these opportunities through the Council of Medical Specialty Societies and our Specialty Society CEO Coalition have really afforded me the chance to have radiology be really discussing common issues across the board. But I really have to disclose how much I appreciate our collaborative effort in this specific instance with the American Society of Anesthesiologists and the American College of Emergency Physicians, and our really multi-talented ACR staff who really continue to navigate what's you'll hear tonight is really a tortuous path of implementation of the No Surprises Act. So my objectives this evening are to take a minute to describe some necessary ingredients to be perceived as a good collaborator, and then provide some background on the early development of the No Surprises Act, and then discuss the various levels of collaboration that have occurred and continue to occur both inside and outside the college that have been utilized to remain in play, because these will continue to go with us as we move along. I'm not sure if this is displaying. I'm going to try to, there we go, get that out of the way. So again, let me, all right, so a problem, there was no question in the problem. That is that the patients were really suffering, that medical bills were the #1 cause of bankruptcy in the United States. And the patients really were usually innocent, but bear the brunt of the impact. And so there really was no question about that common problem, but there really was disagreement on the cause of that. And that is the health insurers were reporting to what they call egregious, and they use specific examples. They were definitely out there and had a public campaign to use those extreme but real examples to get ahead of the message. Whereas providers in our societies were describing inadequate networks. That is, insurers were not negotiating in good faith to establish a complete spectrum of the specialties that might be involved in an episode of care. But our specialties, we had to continue to battle this perception that was created by the insurance industry as the greedy doctors trying to charge these out of network rates. So let me go to how is it that we choose or try to qualify ourselves to be a good collaborator. First, you've got to have obviously common interests and desired outcomes. You've got to know what you're trying to accomplish through that collaboration. You've got to have organizations, you want to collaborate with organizations that have credibility. And that's really hard to build and quite frankly, very easy to lose with a misstep. And I'm really pleased to say our collaborators in this particular instance have just been terrific. You don't want to do anything in the process to taint your message or your reputation, because again, if others are looking for collaborators, you want to be perceived as a trusted and a trustworthy source. And then in the collaboration, you've got to be willing to take a long-term outlook as far as the outcome of that collaboration and the commitment to stick with it. And as you will hear, the multiple stages of the different lawsuits and the like really show the commitment of the organizations with whom we're collaborating. We had a long history, the American College of Radiology with the American Society of Anesthesiologists, all the way back in trying to make sure that the radiology, anesthesia, pathology stayed in Part B of Medicare and successfully did so. In the 1980s, we had the Reagan administration with their so-called RAPS proposal, radiology, anesthesia, and pathology, and then emergency medicine, which was evolving as a specialty at that time, came into this group with our very common interests. And as an example, we have the so-called hospital-based coalition that meets during the AMA meeting, both the annual and interim meetings. So a real good, tight group has been developed over time. Now, the first round of our real act, as Josh talked about, we had been working on this really back to early 2019. In 2018, actually, the Brookings Institution came forward with a proposal to bundle ER services and in that way try to get patients out of the middle. We had a congressional briefing that was arranged with the American College of Surgeons as our moderator, and I had a chance to attend there and present to these congressional staffers as well as members of Congress, as well along with members of the ASA and ASEP. And again, really was a terrific opportunity to get the physicians and providers message out there in front of that group that was actively analyzing the various bills or drafts of bills that were coming through Congress. The out-of-network spending is again here in June of 2020. The heat was rising, and this was an article from Health Affairs talking about why there was growing attention on what was really a relatively small share of medical spending, but it was really leaving so many patients and families out because of the out-of-network charges that they were receiving. So as Josh pointed out, the final No Surprises Act really was well negotiated with important things. The patients were out of the middle. That was really a primary goal. Again, it was, as was stated, Greg told us there was no threshold in order for an out-of-network providers to be able to enter the process. And there was a balanced, and by the legislative language, it really is a balanced independent dispute resolution process with many factors that had to be considered, and none were given any primacy as Greg described. So again, here we are now moving forward. The bill has been passed. And so in February of 2022, this was really lauded as a bipartisan achievement to protect consumers from unexpected medical bills. And again, fortunately, that part of it has really been preserved despite all the legal wrangling that you'll hear about that has gone through the cycles because of the implementation effort. And that's exactly what, as Yogi Berra said, it ain't over till it's over. We had a good legislative success, but in fact, now the implementation began, and that's where the games, unfortunately, and challenges really came upon us. So here in August of 2022, the guidance was put out based on the first interim final rule, and we know, as was described, was then supplemented by the second interim final rule that really gave guidance that really put providers on the short end of that negotiating stick and really tipped the scales towards the insurers. So we were back together again, not just contesting with CMS, but again, the three agencies that were cited, Treasury, Labor, and so the suit that we filed along with our anesthesia and emergency room colleagues was in fact naming the three agencies and the heads of those agencies as the defendants in the case, in each of the cases. We convened weekly Zoom calls, which now are every other week, that involved our volunteer leaders and key staff in order to make sure that there was continuous coordination and collaboration throughout the process. And there was joint decision making with regards to funding the lawsuit and also funding the additional research in order to be able to strengthen our arguments within the lawsuits. There was terrific collaboration by the staff, both within each organization and across organizations. And of course, it involved the legal, the GR, the regulatory personnel. Our marketing and communication expertise was really critical as far as getting our message out there. A constant communication between the three organizations, and that involved multiple press releases that you've seen on the ACR website over the course of this interaction, both jointly with the other agencies, but or with other organizations, but also individually. Each of the organizations needed to reach out to their members and their chapters, as Greg described, trying to find examples, because unless you could demonstrate harm that came as a result of that implementation of the rule, you really don't have any grounds for a lawsuit. So we all reached out to try to find those examples, and Greg has described the North Carolina Blue Cross Blue Shield, who, to our benefit, fortunately tipped their hand very early on after the issuance of the interim final rule. Other state payers acted similarly, and just to give you, again, this is the letter from North Carolina that said that the No Surprises Act in December of 2020. So they actually said that that was the basis of this these letters that were going out, that the payments will be set for out of network at the qualifying payment amount. So right off, they've tipped their hands. And then also in the letter said the new federal law allows a significant change to Blue Cross and Blue Shield of North Carolina's contracting approach. So this bad behavior that we had told Congress and told the agencies was going to occur was in fact right out there in front of them. So there was other research that needed to be done in order to demonstrate the impact on these issues that were being contested in the lawsuits. We use our ACR networks, the multiple networks, to look for examples of practices that were impacted because of the IDR dysfunction. Again, we cannot collect charges, but we can certainly collect the data that shows that there's a aggregate a shift in the strength of the of each of the positions, that is the insurers versus the providers. And all three societies got together financially and commissioned the research to investigate the ghost charges that Greg described to you so well, that would falsely decrease the qualifying payment amount. None of this can happen without terrific leadership, and my thanks to Dr. Jackie Bello, our chair, and Dr. Howard Fleishon, our president, and honestly, and all of the dedicated staff that's been committed throughout this collaborative effort. So let me turn the next segment over to Dr. Fleishon. Thanks for your time, and I look forward to the Q&A.
Bill, thank you very much for covering all that really important leadership opportunities and leadership activities that occurred. Our next speaker, Howard Fleishon, will talk about leadership challenges and advocacy and all those important details. Howard?
Thank you very much, Bob. Let me just turn on my video. There we go. And hopefully you can see my slides. Thank you for the invitation to present. Certainly an honor to be here with the other presenters on this very important topic. And I'll be focusing on the NSA leadership challenges. So I have no financial disclosures, and as Bob mentioned previously, I do have the honor to serve as your president of the American College of Radiology. Here's a brief overview for what I hope to cover tonight. There might be some overlap with the other presenters, but that's mainly for emphasis of important points. I talk about the issues, government relations, the power of the coalition, our communication issues, and also the legal timeline. First, surprise billing is a significant issue. It's a significant issue for both patients and for us as physicians. Here are some numbers from a study based on the claims between April 15th and September 30th of last year. 72% of disputes involved emergency services, 24% involved non-emergency services, primarily radiology, anesthesiology, pathology, and air ambulances services made up the remaining 4%. Various studies have indicated that about 20% of emergency room visits and up to 16% of in-network hospitalizations have resulted in surprise medical bills. This graph demonstrates the acceleration in claims since the IDR process was instituted. Texas providers led in IDR initiations by a large margin, with Florida, Georgia, Tennessee, and North Carolina providers rounding out the top 5. At the beginning of May 2022, roughly 700 IDRs had been initiated. That number rose to above 7,000 by the end of May, and 6 months later, 120,000. As Bill mentioned, we participated in a study published by Avalier in August 2022 that documented the quote-unquote ghost pricing in the QPA calculation that Greg talked about. I won't go into further details here in the interest of time. We can go into more detail during the Q&A session. So the ACR is widely recognized as the largest and most effective lobbying organization for radiology. A vital component of those GR activities is the commission, made up of staff and the members active in advocacy throughout the country. In December 2020, we were focused on the Consolidation Appropriations Act and how to mitigate the double-digit hits to our reimbursement. NSA began gathering momentum at the same time. With the discussion at the commission level, it became clear that ACR needed to get directly involved in the NSA also. Resources were reallocated, so we had influence in the final NSA bill. This illustrates several things. First, government relations is a moving target. While we can plan and strategize, the pace of change in Capitol Hill requires us to be very, very nimble. We often have some periods of relative calm, but we are always prepared for rapid change. And finally, while the ACR has experienced and talented staff, our effectiveness relies on membership engagement and advocacy throughout the commission, throughout the Radiology Advocacy Network, RADPAC, and the state lobbying efforts. We're all in this together. The power of coalitions. Bill has already underscored the relationship with ASA and ASCP. Instead of 40,000 radiologists as a single specialty, we are now over 140,000 physicians strong. We have gained a much higher profile along with synergy of combining information and resources. Along with our political and legal strategy, as we're outlining, communication has been critical, both internal to you, our members, but also to media, and most importantly, to our patients. The issues involving the NSA, the interim rule, and implementation are quite nuanced. To be clear, we lobbied for and we are fully supportive of taking the patients out of the middle. Surprise billing is the result of multiple market failures. Insurers frequently will not recognize the value of medical services, especially in emergencies and in underserved areas. The NSA was carefully negotiated to be a fair balance between insurers and physicians while limiting the financial exposure of patients. But you can appreciate that how we voice our position needs to be very consistent and very clear. So for our members, we've used several venues to communicate updates. Hopefully these have been a significant source of information for everyone, including Advocacy in Action, Radiology Smart Brief, the weekly member updates, the social media, website, and press releases. For non-members, the messaging has to be a balance of explaining our position while being sensitive to the significant impact of surprise billing that we've outlined previously. Here are a few samples of statements from opposition that have been published. The law prevents providers from leveraging surprise billing to extract higher prices. And another example, 2 million surprise billings prevented and up to 2 million will be avoided. And still another. The CBO estimates that the NSA will save taxpayers $17 billion over 10 years and consumers twice that amount. And still another. Many providers, including those backed by private equity, have historically had very high charges, which has contributed to higher medical costs. So here's a sample of our press release. Please note that we emphasize the following. We support taking patients out of the middle. That's critical. That's been consistent from the very beginning. And we support the language and the intent of the original legislation. Now I'd like to present a brief timeline of the NSA lawsuits that Josh alluded to. So we filed our suit in December 22nd of 2021. Our logic to follow the suit was based on the following. First, the chances of a legislative fix were pretty small, and they're still fairly small. Congress has considered the matter addressed in the 2020 legislation. We were one of 6 lawsuits filed against the NSA interim rule in late 2021, all seeking an appropriate judgment. Another suit, contemporaneously followed by the Texas Medical Association, was decided on February 23, 2022. The ruling was that parts of the interim rule related to the independent dispute resolution process were inconsistent with the legislation as written, that federal agencies violated the Administrative Procedure Act, and that the challenge provisions should be vacated. The government moved and the ACR agreed to stay or pause our particular lawsuit until a new final rule was released to comply with the TMA ruling. The subsequent final rule still failed to address the disputed issues. In response, the ACR re-engaged our lawsuit. In addition, the TMA followed a second lawsuit, TMA 2, in September of 2022. Contemporaneously, AMA and AHA elected to withdraw their lawsuit and threw their support behind the TMA effort. The thought being that once establishing a successful judgment, concentrating resources was the best approach. ACR also elected to withdraw its lawsuit, quote, without prejudice, end quote, on October 20th, 2022, and submitted an amicus brief for TMA 2. Recently, judgment came down in favor of TMA again in TMA 2. TMA 3 was filed in November 3rd, 2022. The plaintiffs are contesting the methodology in determining the QPA and that regulations unfairly deflate the QPA, some of the issues that Greg talked about. A court date has not been set for this filing. Finally, TMA filed a new lawsuit, TMA 4, on January 30th of this year, challenging the 600% hike in administrative fees. The complaint argues that the fee hike will restrict many physicians' ability to seek arbitration. Additionally, TMA 4 challenges the restrictive rules on batching claims that Greg had talked about. At the heart of the NSA legal dispute is the interpretation of the 2020 NSA legislation by CMS. In the past, based on a precedent set by an historic case known as Chevron, the courts have typically given deference to the regulatory agencies. Without being partisan, since administrations both sides have been accused of overreach, recently courts have begun to reconsider that approach. In our case, the NSA case, we continue to face formidable opposition in the government and the insurance providers. But this is a battle that we will continue to fight. The issue of the surprise billing and its potential, if not realized, impact on the good faith practice negotiations with insurance companies goes to the foundation of how we continue to provide access to services for our patients. We will continue our engagement with the legal system to make this right. If it makes sense or the opportunity presents itself, we'll also pursue a legislative remedy. And all the while, we continue to rely on your engagement and your support. So thank you, and we look very much forward to the QA session.
Howard, thank you very much for covering all those serious challenges to this NSA enactment. We look forward to our next speaker, Tom Hoffman, who will talk about our path forward, current activities, and plan of action and updates. Tom?
Thanks, Bob and Jen, and to my co-panelists and my staff colleagues, Jen Pendo, Anne-Marie Pasco, and Melanie McGraw, for making tonight's webinar possible. All right. Pardon me, I just click off and reshare. All right, I hope folks can see my slides.
Tom, you might want to go to full screen at the bottom.
Sure. Yep. There we go. Thanks. As my colleagues have described, the college as engaged in history. And like Josh, I too have been privileged to serve at the college for 25 years. And this is the first time in our tenure and indeed in the college's history in which ACR has sued the federal government as a plaintiff, gone into court and handed down a complaint along with our coalition partners, the anesthesiologists, emergency physicians, and asked a judge to rule for physicians for quality patient care against a government overreach. So I'll describe in the next 5 minutes the lay of the land, legally speaking, and then turn it over to my colleague Elizabeth Rula for her overview on research initiatives through the Health Policy Institute. We had to act nimbly throughout this whole situation because the landscape has shifted dramatically, even beginning from the first TMA lawsuit in October of 21, and then joining the fray ourselves by late December of 2021, and then Texas Medical Association obtaining the first win in the NSA rubric of cases by early 22. We realized by the spring of 2022 that the TMA lawsuit was the best point of leverage for our members and their practices in tackling a very flawed implementation process. So by the last fall, we pivoted from being a tri-plaintiff in our own case in the Northern District of Illinois to joining as a friend of the court or an amicus along with the anesthesiologists and the emergency physicians in the TMA2. Why did we do that? We understood that our lawsuit, along with the lawsuits that TMA, the American Medical Association, and Hospital Association, all had addressed this IDR language in the interim final rule. But when TMA drew first blood, legally speaking, and received that great decision from the judge a little over a year ago, we realized that the iron was hot there in the Eastern District of Texas. As my colleagues have noted, although the government reacted to that TMA lawsuit and decision and withdrew the offending provisions of the independent dispute resolution process, it basically issued a second rule that was no better. And as we'll soon learn in the TMA2 decision, the government tried to do indirectly, tried to pull an end run, that which it could not do directly in the first TMA matter. Once we looked at the final rule, the revised IDR rule that the government issued last summer, we all agreed as a coalition that there were still significant problems with how the qualifying payment amount would be addressed. So then why take the amicus route? Home court advantage and capitalizing on TMA's legal success. The judge was familiar with the case law, naturally had made that precedent himself. Why go to a different court and have to re-educate a new judge about not only the statute, but most importantly about the regulatory process that led to that challenge? We had filed a lawsuit in Illinois back in late 21 and into 22 based on the first couple of independent dispute resolution rules. That had changed by last August. So now it's time to change our tactics to look at the new IDR language. With TMA's victory, we wanted to, along with ASA and ASAP, put our chips, if you will, behind that. So we withdrew our own lawsuit in Illinois, but we did reserve the right to come back into the court and to sue again if the government failed in the TMA cases to remedy the flaws in the IDR process. The advocacy in the courtroom experience has been fascinating, as you might imagine if you've been in one yourself or through your practice or other colleagues. That is, the arguments that you make and that you hear your opponents make in court often will turn the balance one way or another. Last December in the TMA2 case, Josh and I were listening in on the hearing that, sorry, I'm just advancing slides here.
You're fine. Go ahead.
All right, thank you. Up to the TMA2 case, And in the hearing in the TMA2 case, the court seemed more inclined, seemed more favorable to the position, the TMA position. And that bore out within a matter of weeks, as my colleagues have previously indicated, that early this month, just a couple of weeks ago, the TMA judge ruled for the TMA and its members, along with the college and ASA and ASEP as friends of the court. So the great outcome here was predicated on the government still mishandling the qualifying payment amount process, and that the court invalidated it not only as applied in this case, but generally across the board. So therefore, this had nationwide impact and was truly precedential and 2 for 2 in the TMA legal world. Finally, the other 2 cases, the TMA3 and TMA4 case, involved, as was been noted, the third challenge against the flawed QPA methodology in the 2021 rule, the lack of transparency here. The first 2 cases focused on the QPA itself as the primary concept. We also threw our hat in the ring, legally speaking, with ASA and ASEP submitting a supporting amicus brief. That's been a strategy that has proven successful in the prior 2 cases, and we are confident in our chances of success for the TMA3. And finally, the 4th suit that has just hit the courts in the last 2.5 weeks does address the IDR dramatic fee hike and the batching complaints. We are, as we speak now, presenting the webinar tonight, will join with ASA and ASEP and submit a supporting amicus brief by this time next week. So to reinforce, this whole experience has involved history, and as Howard noted, agility, being nimble. Cases have been moving fast and furious, receiving decisions that have given us hope about the courts supporting physicians against the government, but still having us step back and decide how best to present our arguments. And the joint experience with ASA and ASEP has been extremely rewarding. We've benefited from their legal counsel and their regulatory prowess here in the legal landscape. So I too look forward to talking with you in the Q&A session. I'll next turn to my colleague Elizabeth Rula for HPI research. Thanks very much.
Thanks very much, Tom. That was a great review of all the legal challenges and insights into how it worked. So we're going to go to our final speaker now, Elizabeth Rula, who will talk about the research aspects of the NSA. Elizabeth?
Hello, everyone. Thank you for joining us tonight, and thank you for putting together a good program. I'm going to spend a few minutes tonight updating you on the policy research priorities related to surprise billing legislation. I have no disclosures. The Harvey L. Neiman Health Policy Institute has been working very closely with the other areas of ACR represented here tonight to develop a data-driven strategy and provide objective evidence to demonstrate the issues that you're hearing about with how the No Surprises Act has been implemented. The topics I'll talk about are, by design, the issues highlighted by other speakers this evening, and I'll talk about how we're working to address these through research. One of the reasons that the ACR was positioned to be a strong leader in advocacy with other medical associations was because of our extensive expertise and resources in economics, advocacy, legal, and also policy research. To date, my group at the Neiman Health Policy Institute has collaborated both on some of the studies you've heard about today and also on 2 additional published studies on this topic. Most recently, a review of what neuroradiologists need to know about the No Surprises Act, which is really a review of what all radiologists should really know about the No Surprises Act. Some of the major issues that we addressed in this article include the benchmark approach using the QPA, despite the legal rulings against the QPA as the standard payment in the IDR process. as written in the interim rule. Since the time of this paper, the final rule still places primacy on the QPA. And there are a number of reasons why the methodology for calculating the QPA is troublesome that I'll discuss later. Another issue with the QPA is that it disincentivizes health plans from maintaining robust provider networks because the out-of-network rates are essentially capped. As you saw in prior presentations, payers have taken action accordingly, sending in-network providers to take it or leave it offers, requiring them to take a substantial rate reduction or to have their contract terminated. So while protecting patients from surprise medical bills is incredibly important, we see this good policy implemented in a way that is likely and starting to cause harm. To summarize the priority issues that we are spending our days researching, first is protecting patient access and equitable care. This relates a lot to the observed behaviors of insurers pushing providers out of network. A big concern here is, how does this breakdown of networks impact patient access to care? Access is something that the government should and does really care about, and this should be a good platform for change. Another big area is determining the appropriate payment for medical service, addressing whether the qualified payment amount is a reasonable benchmark, and then also the independent dispute resolution process. Is it accessible and fair given the fee escalations that we have observed, as well as the constraints that preclude much batching of claims within this process? So digging in a bit to the qualified payment amount and why it really isn't qualified to do the job it is intended to do. You've heard a number of times about the QPA tonight. As a researcher, I'm fascinated by how a methodology has been enacted for determining the QPA that has, as far as I can see, not been tested, because there are numerous issues that make it impossible to calculate a QPA using the full methodology in many cases. So let me try to explain. So the QPA is, as you've heard, is the basis for determining individual cost sharing under balanced billing protections, and it remains the basis for that. And it still must be considered first for determining the payment amount in the IDR process. The QPA is determined as the median of contracted rates for a plan or issuer. So that is the median of the contracts with practices, not of actual paid claims. So each practice is considered equivalently, no matter how many times they bill for a given service. Another requirement is that the QPA be calculated for the same or similar item or service. So we're talking about the CPT code as well as modifier codes. The modifiers can affect the payment amount, and there are documented concerns that payers will downcode when they are calculating the QPA. And they have tried to address this in the more recent final rule, but there is still some room for, definitely some room to understand better how payers are actually calculating this number. The next is it must be provided by a provider in the same or similar specialty, also in the same or similar facility type, and in the same geographic region. So while methodologically it makes sense to compare apples to apples across all of these dimensions, what wasn't taken into account is sample size. So some of our initial analyses indicate that it will be a really common problem, even with with procedures that are performed at fairly high rates, that there will be insufficient contracted rates for a plan to identify a median based on all of these criteria. That's where the word similar that I've highlighted in here is concerning, since it's not defined. In fact, the requirements state specifically that this definition is intended to provide plans or issuers with the flexibility necessary to calculate the median contracted rate, relying on their contracting practices. So, for example, the plan gets to determine what a similar specialty is, or what a similar item or service is. Hence the issue that has been observed with downcoding, or looking at rates for specific services that are paid at a lower rate. So what are we doing about some of these issues? We are at the HPI continuing to collaborate with economics, government relations, legal, and our member experts in this domain, including Drs. Greg Nicola, Josh Hirsch, and Rich Heller, among others. We currently have 3 studies underway. The first of these is an evaluation of the QPA methodology. First of all, answering the question, how often are there insufficient contracted rates to calculate a QPA? And in that case, what is the sensitivity of the QPA's value to the flexibility that has been defined, that has been allowed in terms of defining a service, specialty, place of service, and geography? And how may that actually create a whole new kind of surprise billing, where the payer gets to determine what they think the appropriate rate is? So starting to understand what those potential ranges are based on how a payer could adapt the QPA methodology is really critical, and not just applicable to radiology. Second is the implications of the IDR fee escalation that you've heard about, and the requirements for bundling. So we're doing some work to determine what proportion of radiology services would actually have costs that you'd expect to be more than the $350 fee, where there may be some return on going through the IDR process, not even considering the cost to the practice of going through that process outside of the fees. Also, the batching restrictions. So if there is a 30-day window for services that can be batched together, and that they must have the same service code, how often are there enough claims that could be batched with those restrictions? So really just trying to uncover the practical issues with this process. And then finally, we are starting the process of planning an evaluation of payer network changes and impact on access. As a starting point, we think that a practice survey is our plan for tackling this, to determine how common it is that practices have received letters like we saw in some of the presentations today, and what has been the effect of those, both on the practice, but also on access to care for patients. So in general, we're aiming for this work to contribute credible evidence that will help us better understand the consequences of the implementation of this policy, and that can provide really a strong footing for our advocacy to make sure that patients and physicians are both protected. We'll be balancing getting evidence quickly in the hands of those who need it to take action, but also at the same time doing larger, rigorous studies for peer-reviewed publication, and trying to extend our analyses where possible outside of radiology for the issues that are more broadly applicable to garner larger recognition by policymakers and hopefully have a larger impact. Thank you very much. And I think I'm the last speaker for tonight, so we can move into Q&A.
Elizabeth, thank you for covering all those important research aspects and building of evidence and all the many things you spoke about. Okay, we're going to transfer over now to Jen Nathan, who will moderate our Q&A session. Jen?
Thank you, Dr. Pyatt. So first off, I just want to say thank you to our excellent speakers tonight for your informative talks. So thank you to each of you. So we're now going to move on to the Q&A session. We have had a few questions that have come in. And if you need a reminder on how to submit a question, you can see it here on the slide. So our first question is, what financial effect will this have on radiology? And can insurance use this against us? Anyone want to take a stab at this one?
I can start off. A lot depends on how this next set of regulatory language comes out of the TMA2 favorable decision. If we see that the QPA is no longer prime and that the arbitrators start looking at a lot of independent data, the insurance companies may shy away from this process and may not go after in-network contracting as aggressively as they have out of the start gate. So it's really a watch and see mentality here. We're cautiously optimistic, but there are things that can still not go our way. And we certainly need to watch that very carefully. But certainly the world of out-of-network billing has been changed drastically here. And you are certainly going to have a harder time being out of network. Although I will say most radiology groups had migrated to being in network, especially if you service the hospital. Most of the time, those contracts come with clauses about serving the same insurance companies as they do. So it's probably not as big of a problem as or big of an issue as it used to be in radiology.
Jen, the only thing I'll add to that is, as this process drags on, and you've heard the statements regarding the delays and the backlog that's been accumulated, understand that there were only, I believe, 11 IDR entities recognized, and only 9 of those were functional even before all this. And in the meantime, radiologists, just like other physician providers, are providing the care, and then they get whatever the insurer decides to pay them out of the gates. But they're waiting months, if not potentially, a year or more, to get whatever balance they may be due. So I think it's the question about it being harmful to practices. I think the fact that the agencies came out with this initial attempt at controlling it and tipping the scales in the favor of the insurers, I think continues to drag on, simply because the time value of the money that the providers and radiologists and other providers are not getting paid is really makes it tough for practices.
Mm-hmm.
And I'll just add that some practices have in the past had carve-outs. I think being a network but having carve-outs, I think that approach I think is really in jeopardy with the whole NSA prospect.
Any other comments? Okay, our next question is, any updates on the penalties?
I'll take it. I'm not exactly sure what is meant by penalties. I imagine it's with the fee increases. I hope that's what they're talking about. I think the only update is that certainly the ACR is commented directly to a government organization called SOCIO with regard to the fee increases, and as has been discussed by several folks, the Texas Medical Association has filed a suit basically challenging the increase of those fees.
And as Greg pointed out earlier, there is the loser, if you will, in a dispute resolution is responsible for those costs. So that in essence is a potential penalty if people, if insurers, or quite frankly, if providers aren't participating in good faith. And for those that aren't aware, we didn't mention it earlier, these negotiations, or the dispute resolution, is done in the so-called baseball style, where each party puts in their kind of last and final offer, and then the mediator chooses between them. So there is somewhat of a penalty to the loser of that process of having to bear that second charge.
And there was I think in the legislation, there's buried a penalty for not disclosing prices for self-pay patients. I don't know if that could be the penalty, the good faith estimate. There was in that, and it was in the legislation, but I don't think there's been an update on that.
Any other comments? Okay, our next question is, what should my payment be if I am currently out of network? Do the carriers have to pay at least 150% of Medicare rates to be in compliance with the law? Anyone want to take a stab at this one?
No, I'm not aware that there's anything in the legislation or in the ruling that defines a percentage relative to Medicare payments. And in fact, Medicare payments, as was pointed out earlier, are not to be considered in the evaluation by the arbitrator.
Any other comments?
Jen, I would advise that as fluid rulemaking process as it's been, it reinforces the fact that our listeners, their peer members and their practices should get the best legal and business advice they can. Greg in his practice, Bob, Bill, when he practiced, had an array of people, their business managers as well, who could tackle on a practical level how to fashion the best arguments. And I think that calls, as Dr. Racenstein has teed up here, the real time fee issue. Work with the staffs, the experts who can help you form a game plan.
Any other comments? So our next question is, if QPA is no longer considered the primary factor in the IDR process in the next interim rule, what other factors will be considered?
Well, I'll take a quick stab at that from my memory. The QPA was in the legislation was a list of factors for the arbiter to consider, one of a list of several. Another factor, for instance, was previously contracted rates. So there are several others I'd have to look at the legislation again. But certainly, I think the main point that we've tried to get over with regard to the lawsuits is that the QPA is not the primary, or should not be the primary consideration.
Yeah, there are a number that I can't recall the entire list either, but one of them is the level of experience that the provider has and the level of specialization that is required by the procedure, as well as whether the practice has, in good faith, tried to negotiate being in network for that provider as well. So basically ideally, the whole picture will be taken into account in terms of determining what payment is appropriate without relying on a number that is calculated via what I would consider a flawed methodology.
Yeah, the only thing I'll add to Elizabeth's comment is it actually applies to both sides, not only the efforts that the provider has made to try to be a network, but the efforts that the insurer has made to assure an adequate network. Again, needs to be considered if either side was not in good faith in their attempts to provide that in network care, that would be I guess probably on the negative side of their arbiter's consideration.
Any other comments?
I'll just add that consistent with the factors that we presented previously, the whole idea is to take the patient out of the middle here. So one thing that will not be considered is the patient's ability to pay. So that would not be consideration. Thanks.
Any other comments? Okay, next question is, how can we as radiologists use these changes to our advantage?
Well, one thing for sure is that if QPA is not prime anymore, I think that your chances of losing an in-network contract start to go down because it makes it less likely to argue that. So I think just knowing that you waiting out the lawsuits is very important during this. if you have a chance to even hold off on negotiating a new contract in any way, you probably should wait until some of the lawsuits trickle through. The one thing that may become advantageous in the future is the statute does require an inflationary adjustment to the QPA, which is kind of fascinating and potentially even beneficial to providers, not now, but in 10 or 15 years, with constant adjustments to the QPA, what happens? Because I know our fee schedule hasn't changed all that much over many years of practice. Does this new inflationary pressure, and we've already seen announcements from HHS of what the inflation rate has to be on the QPA from last year, and it was significant. Does that become advantageous to groups at some point? Certainly not anytime soon, but in the future it could be.
And the only comment I'll make, Jen, on regarding the question is, if you decide to pursue independent dispute resolution, and we didn't get into the 30-day period for an attempt at an agreement between the two parties before IDR even kicks in. But if you do get involved in this, be realistic in your filings. It's not a system to try to game. You certainly want to know the factors, as Elizabeth cited, degree of subspecialization that might have been necessary for the procedure, expertise that was required because of the clinical circumstance, et cetera. Make sure that you've got all your ducks in a row, but then at the same time, be realistic about your entry, if you will, because as I say, in this baseball style dispute, you don't want to go in there and really file a number that doesn't make legitimate sense.
Any other comments?
Yeah, I would just add that getting back to the comment about communications, if a practice is approached by a media outlet or even on social media, the essence is the same. I mean, we want to take patients out of the middle. That's not a fair position for patients in need at their time of greatest need. They need to be out of the middle, but also we need to maintain our practices. We have some real challenges in the current reimbursement environment, and so we are negotiating in good faith, and this is a process in order to do that. And right now, there are some very difficult challenges in the process as it's being rolled out by the agencies of concern.
Any other comments? So the next question, I think, kind of touches upon what you were just saying, Dr. Thorwarth, how to cost effectively dispute low QPA payments. So do you think it's more of a game of trying to figure out if it's even worth doing, or?
I'll say, yeah, I think that's the first question any practice needs to ask. Is it worth pursuing this? And again, hopefully we'll be able to, through the TMA4, get a reduction in the entry fee to the point where it's reasonable. And we're actually looking at ways to try to, I've discussed this with Elizabeth, of ways to look at, okay, what percentage of ER cases, patient interactions, episodes of care, what percentage of those even reach the $350, the current entry level? Do you know what I mean? If as one of the attorneys that's involved from the American Society of Anesthesiologists stated, you can get these wins in court, but if you can't get into the process because the entry fee is prohibitive, then it's really kind of a false victory or a paper victory. So I do think that the first thing to do is to decide, can you either through that particular episode of care or through a batch, and hopefully we'll be able to modify and expand the batching criteria, then that it's worth your while in pursuing.
Any other comments?
Yeah, Jen, I'll just echo, I'm sorry, Elizabeth, I'll just echo Bill's comment with regard to batching. I think that's another avenue, hopefully combined with reducing the fee, that if we can simplify the batching process, allowing more services to be batched. I think that hopefully will reduce any type of cost barrier.
And to echo that point, Josh, I think radiologists are at a disadvantage relative to some of the other specialties impacted by the No Surprises Act because of the diversity of services provided. So while an ER doctor may be able to batch a whole lot of E&M services together, when radiologists are providing such a wide array of different imaging examinations, it is difficult to have enough to batch. So relaxing those restrictions in a way that makes sense and also offers practices a potential for ROI. I think that our analysis is going to show some striking numbers in terms of the proportion of radiology services that fall below that $350 threshold. And in fact, that if you have to batch quite a few of a lot of different types of imaging in order to surpass that $350 threshold. So I think it's going to be a pretty striking story that may show how radiologists are more disadvantaged than some other specialties in this.
Any other comments? So our next question is TMA the only organization considering litigation at this point, or is everyone just joining in its success?
TMA is the prime mover legally right now and is batting 1,000 in court, 2 for 2. We just learned today that the judge who ruled for physicians and their practices in the first case also has now received TMA 4. We hope that he'll continue his pace. For the latter part of that question, organizations can make their business decisions right now based on where the odds are. And it is a risk management scenario, I believe. TMA has paved the way along with the support as friends of the court from the college and our coalition partners. So that's probably a strategy that will continue.
Any other comments?
So Jen, if I may, it's been an interesting learning experience for us because most of our experiences come from the advocacy end. We have very sophisticated advocacy efforts and very well-experienced staff, very talented staff. This is different. This is coming from a legal aspect dealing with the regulatory agencies. So we rely heavily on our legal consultants and guiding us through this quagmire. But it's a different, I don't want to use the word game, but it's a different situation that considers a different type of philosophy and approach. So it's one that we rely highly on our consultants.
Any
Jen,
other
the only thing I'll add to Tom's comment is this was very strategically decided to put aside our case, which was with the 3 organizations in Chicago or in Illinois, a federal case. Because if we were to have come up with an adverse ruling, now you've got 2 dueling rulings. Do you know what I mean? So the reason why everybody sort of jumped on the support of the Texas suits has been, we've got a court and a judge that has already shown favorable rulings. Best to continue that, and those rulings are, it's a federal court, so it is in fact nationally applicable.
And that's a great illustration, what Bill was just talking about. What also happened contemporaneous with that decision was that the AMA and the AHA withdrew their lawsuit. So the question would remain, well, why is the ACR and their partners still engaged in this process? Well, somebody with such a high profile such as AMA withdrew. So it's these kind of issues that it's just a different environment in the legal arena.
Any other comments? Okay, so this is our last question. So given all that the ACR is doing on the NSA situation to help members, what can members do to help the ACR with this fight/process?
Well, I'll answer that one first, and I think everybody else probably has the same answer. If if anybody runs into any kind of problems that we described with insurers, please let us know if anybody has any data on how their contracts may have changed, or if they get some type of abrupt communication from their insurers, please let us know.
Yeah, no, just mention that, and we can't collect data about a practice that says, well, I submitted this charge or that charge. That we really can't accept or deal with. But I would want to echo Josh's comment, and I hopefully made the point during my segment that the collaboration is not just us with the other organizations. We need to really depend on the feedback from our membership to keep us informed of bad behavior that may be occurring out there.
And I'll lob onto that as well. In the beginning of this process, we were not hearing very much from our practices. Perhaps it gave us lessons learned in two-ways communication. But as the process moved forward, we were learning more and more. And as we reached out to practices, whereas our partners were hearing a lot from their constituents. So as we mentioned, we're all in this together. This is a team process. So if your practice is experiencing difficulties, please let us know so we can consolidate all these experiences.
Any other comments?
Jen, I'm going to go to the question that just appeared about a national strike. Legally speaking, the college has to stay far away from advocating that our members and their practices take collective action. We don't have a policy that the council has passed, but more importantly, as a matter of risk management, reputational risk, I appreciate the passion and know that those are on the front lines trying to provide the best care they can in as cost-effective way they can, believe that some type of concerted action might be the resort, but it's going to take time and money, and I believe just be the wrong path that will detract from the strides that we have made through the college, but throughout medicine.
Any other comments? All right, so with that, we'll conclude our webinar. I'm going to turn things over to Dr. Pyatt. Let's see here.
Thank you, Jen.
Find the conclusion slide. Let me get to it real quick. And this one. Okay, here we go.
Here we go. Great. On behalf of Jen Nathan, my co-moderator, and I, we would like to sincerely thank the 6 all-star faculty that we had for tonight's strong program on the NSA. And we also like to thank everybody in the audience for attending this program and doing your part to help us through this whole process and answer practices for your group members. So please share your feedback with us. We will be sending out a post-webinar survey, and a recording of tonight's entire program will be available next week. Our next Power Hour program is entitled Making the Leap, Transitioning from One Practice Setting to Another. And this will be held on Tuesday, April 4, 2023, from 7 to 8 p.m. Eastern Time. You can register for this and other upcoming RLI Power Hour webinars at acr.org/Power Hour. Again, thank you to all of our faculty and audience for attending tonight's program. Have a good evening.